Hey everybody, Gavin Greenfield here from the home office. We're going to talk about bicarb. What are we doing with bicarb as a therapeutic agent? We're going to talk about bicarb in the context of a metabolic acidosis in the absence of a specific indication. So we do have specific indications for bicarb. Hyperkalemia, for example. Bicarb lowers the pH, which allows H plus to come back out of the cell, and it shifts the K plus into the cell in exchange. TCA or other sodium channel blocker toxicity, that sodium channel blockade is pH dependent. There is more sodium channel blockade at a lower pH, so giving bicarb raises the pH and lessens the sodium channel blockade, thus lessening the toxicity. ASA overdose, alkalizing the urine, promotes the excretion of the salicylate. And then true bicarb loss. So this would be like a non-anion gap metabolic acidosis or a hyperchloremic metabolic acidosis. They're essentially the same thing. An example of that would be something like renal tubular acidosis. So those are all pretty well accepted indications in 2021 for bicarb use. We're going to talk about bicarb in the context of when we often give bicarb, like cardiac arrest and their pH is low, or sepsis or septic shock and their pH is low, or diabetic ketoacidosis and their pH is low. What is the utility of bicarb in those situations? We need to discuss how bicarb works or dissociates in the body. So you get this equation is in constant equilibrium, moving either to the left or to the right depending on concentrations of bicarb and CO2. So if you give a bunch of bicarb, you can see that that's going to tilt that equation toward the left, and much of that bicarb is going to dissociate to CO2, and we know CO2 is an acid. On the other side, if there's a bunch of CO2, we know that there's going to be dissociation, and we're going to increase our bicarb to try to bring that pH back up toward normal. So let's talk about why we think bicarb may be helpful and why maybe it may not be helpful. So it raises arterial pH. So we get that gas and it shows a pH less than 6.8 or some really low number, and it does tend to raise the arterial pH. It can make that number better. Interestingly, some literature suggested that it may actually lower the central venous pH. So we can make certain numbers better, maybe we make other numbers worse, but the bottom line, does it improve outcome? And we don't know. These last 2 points have been, dogma. Myocardium doesn't contract well at low pH, and catecholamines are less effective at low pH. And, I think that's true, but when you look in the literature, there's animal studies. There's really, I'm not sure there's any outcome data around this dogma that has been taught in medicine and nursing and paramedicine and, for years. So, while that's probably true, does it affect outcome? And I've seen lots of diabetic ketoacidosis, patients with diabetic ketoacidosis who have had profoundly, in fact, unmeasurable pHs on our hospital blood gas machines, so less than 6.8, whose blood pressure has just been just fine. So their myocardium appears to be contracting well enough in that acidemic state. Regarding hemodynamics, there's been no literature that's demonstrated that hemodynamics are improved with bicarb versus just giving normal saline and expanding their volume. Reasons against it, so it may worsen intracellular pH. Remember that equation I showed on the previous slide? Bicarb will dissociate to CO2. CO2 diffuses across cell membranes faster than bicarb does. So if the body sees a bunch of CO2 because of a bicarb load, that CO2 can diffuse across cell membranes and actually cause an intracellular acidosis. What does that mean? I don't know. But again, we're just talking about physiology here. We know that bicarb decreases ionized calcium levels. So we talked about how the myocardium doesn't contract well at low pH. Well, the myocardium also needs adequate levels of ionized calcium to contract, and bicarb lowers ionized calcium. So theoretically, that could make things worse. It decreases, bicarb decreases serum potassium levels. It's a treatment for hyperkalemia, so that's not always beneficial. It increases serum sodium levels, which in certain patient populations is not beneficial. Alkalemia is bad for patients as well, and if we give it without knowing that pH and actually make that patient alkalemic, that has been shown to worsen outcomes. It shifts the oxyhemoglobin curve to the left. It means the hemoglobin is going to hold on tighter to that oxygen, and we'll talk about that on the next slide in a second. And the big thing is, again, there's no outcome data to show that bicarb improves outcomes in this patient population. And it does add to the cognitive load, keeping it around in our treatment arsenal, and maybe that detracts from some more useful therapies. There is a star here. There is a subset of patients that in the ICU population, the patients with metabolic acidosis and concomitant renal dysfunction, there is some data that they may do better with bicarb. But often hard to know that, and certainly many of our patients with sudden cardiac arrest have no concomitant renal dysfunction, and in fact probably most of our patients. So let's talk about that oxyhemoglobin dissociation curve for a second. In an acidemic environment, the curve shifts to the right. Okay, you can see the increased H plus shifts that curve to the right. The decreased H plus, or an alkalemic environment, shifts that curve to the left. What does that mean? Hemoglobin is just a transport vehicle. Oxygen binds to hemoglobin. Hemoglobin transports it out to the tissues, the myocardium, the brain, everything, where it's used as a fuel. But it needs to dissociate. The hemoglobin has to give it up to the tissues at the tissue level. So the more that curve is shifted to the left, the tighter the hemoglobin holds on to the oxygen, and it won't give it up. So let's look at some real numbers. So if we had a tissue level, let's pick a number. The PO2 is 40. If we go straight up here, we're gonna see that the SAT in a right shifted curve, so in an acidemic environment, and obviously depends how acidemic, the curve will shift more to the right, the more acidemic. But in an acidemic environment, in this example, in this curve, the SATs are 60. At a PO2 of 40 in an alkalemic environment, the SATs are closer to 80. So that means that hemoglobin is only able to desat to 80 at a tissue level when they're alkalemic. Whereas when the patient is acidemic, that hemoglobin can desat all the way down to 60. So it has a far greater ability to give up oxygen at a tissue level when the pH is low. So another theoretical reason why bicarb may not be beneficial to patients. So what do the guidelines say? Credit to Dr. Braden Teach, MERGE doc here in Calgary, who gave a good talk on bicarb back in 2018. This slide I, for the most part, just copied, so thanks, Braden. You can see that back in the 1970s, we were given 3 amps of bicarb empirically. This was from, what is now called ILCOR. In 1980, that softened a bit, but it was still indicated in metabolic acidosis. We were given, 1 amp of bicarb. And then in the last 30 years or so, this has softened. And it's plus or minus because the words now are considered, because we started to realize that there isn't any outcome data and no good evidence supporting its use. So what do the guidelines currently say? So let's look at 3 different ones. We've got the Surviving Sepsis campaign. This is a great online resource. I believe this is due to be updated in 2021. They got a bit sidetracked with putting information out around COVID, but I suspect we might see something later this year from this group. But if I orient you to what here, they're against the use of sodium bicarb if the pH is greater than 7.15. Okay, so they recommend against using it. Now, what about the pH less than 7.15? They address that down here. There's basically no recommendation. There is no data. There is theoretical reason why not to use it. They mentioned sodium and fluid overload, increase in lactate and PaCO2, and a decrease in serum ionized calcium. But the directness of these variables to outcome is uncertain. So there is no recommendation in that patient with that more severe pH. So they don't make a recommendation. And that's been unchanged. That was their stance back in 2012. No studies have examined the effect of bicarb administration on outcomes. That was from 2016. Diabetes Canada is a great resource. It's tons of good information online, including information around hyperglycemic emergencies and specifically DKA. And this is a screenshot from those recommendations. You can see the last paragraph. Use of intravenous sodium bicarbonate to treat acidosis did not affect outcome in randomized controlled trials. Sodium bicarb therapy may be considered in adult individuals in shock or with arterial pH less than 7. Potential risks, they give you a little recipe of how you can give bicarb in that situation, but again, may be considered is the language. Potential risks associated with the use of sodium bicarb include hypokalemia and delayed occurrence of metabolic alkalosis. So again, there's no recommendation to give it, may be considered. Finally, ILCOR 2020, their ACLS was updated and the treatment recommendation is unchanged, and routine administration of sodium bicarb for treatment of in-hospital cardiac arrest and out-of-hospital cardiac arrest is not recommended. So what do we do? We still see it being used all the time. What do we do? Let's look at these two things first. So we're going to still give it as a treatment, especially if they're acidemic in a patient with hyper-Ka. We use other things before bicarb for the most part, but it can be helpful in a patient that is acidemic with hyperkalemia. We're still going to use it in sodium channel blockade toxicity, including TCA overdose, and we're still going to use it in ASA toxicity. When are we not going to use it? And the X is a soft X here, but we're not going to use it in sepsis or septic shock, in DKA, in cardiac arrest, other causes of metabolic acidosis. I'd like to talk about this quote for a second. This is by a gentleman named Shane Parrish. Generally, the people who know the most about something talk in terms that involve uncertainty. Generally, if, but, yet, possible, unlikely. People that know the least tend to talk in absolutes. Always, will, never. The language you read and hear, be it online or in person, is a proxy for quality. While we have a tendency to seek out certainty, nuance is generally more accurate. So what am I saying here? Like, I don't think this is like a hill to die on. If somebody asks you to give bicarb, go ahead and give bicarb. But do know there's as much physiologic justification to not give it as there is physiologic justification to give it. And there is no outcome data, apart from that small population with concomitant renal failure and metabolic acidosis. But outside of that, there's no outcome data. So, my personal practice is to use it less and less. And I can tell you, a colleague of mine here in Calgary named Dave Lendrum knows this well, because I handed over in the course of like 9 months when he was a very junior staff, like 3 of these DKA patients. Luckily, I saw them all early in my shift, and they all had unmeasurable pHs, and they all did fine with treatment of DKA, not with given bicarb. None of them received bicarb. So, what's my point there? If someone asks you to give it, sure, go ahead and give it. If you choose not to give it, you consciously choose not to give it, and then someone asks you after why you didn't give it, I think you've got some discussion points here to have with that person. And so we can continue to grow and understand that while almost dogma amongst some practitioners, it shouldn't be dogma for all the reasons we presented here. And my fear is that keeping this in our treatment arsenal, it may detract from other therapies that are likely of greater benefit, like good chest compressions, appropriate treatment of the underlying disorder, that sort of thing. So, yeah, so there you go. That is bicarb in a nutshell. And thanks for your attention, and hope that was useful. And hit me up with any feedback, either personally through email or in the comments for this video. Thanks all. Happy remainder of our beautiful Canadian summer. Hi all. One thing I realized I forgot to mention, so this is just a couple days later, was around what happens, like why to give bicarb. So sure, give bicarb, but we know this equation is in equilibrium, and then a lot of that bicarb is going to go to CO2. We have to be able to ventilate that CO2 out. So I can think of some scenarios where that may be problematic. Let's think about that patient with diabetic ketoacidosis that has a severely low pH. They are breathing quickly and they are breathing deeply, Kussmaul breathing. So adding a large CO2 load to that patient, they may be at max minute ventilation already. And so they may not be able to increase it further to ventilate that out. A patient with asthma with a severe acidosis, often it's mixed with a respiratory and a metabolic component. But here's a patient that can't exhale because of the severe bronchoconstriction. So giving a bunch of bicarb with a lot of that going to move to CO2, but then that patient may not be able to ventilate out that CO2 because of that underlying disease state being asthma. And we just may worsen their respiratory acidosis, and that's often what we see. Actually, we presented a monthly e-learning case recently around that, and you could see that in the blood gas, that the bicarb went up with administration of bicarb, but so did the CO2, and the pH didn't change very much. And then think about your patient that's intubated and ventilated that maybe is a little hemodynamically tenuous. If we give them a bunch of bicarb and their CO2 goes up, and now we try to increase their minute ventilation to ventilate out that CO2, well, we know that comes with potential cost, and that cost is in the form of increased intrathoracic pressure overall, and that can impair hemodynamics, and that can also lower the Q and prevent you from accomplishing what you're trying to accomplish, which is perfusion to the lungs, which is CO2 rich, that pulmonary arterial blood that goes into the pulmonary capillaries so that it can diffuse out and then the CO2 can be ventilated out. Well, if that Q drops remarkably because of or significantly because of the increased intrathoracic pressure, well, now we're not delivering much CO2 to the pulmonary circulation because the Q's down. So anyways, other things to think about, but if you do give bicarb, the patient does need the ability to ventilate out that CO2 that is produced to see the beneficial improvement in the pH. That's it. Thanks all.